hear you.
Okay. Good afternoon. This is Mary Sue Lanigan. I'm the Executive Director of the Michigan Parkinson Foundation. We are all delighted that you joined us today. It's a beautiful day here in Detroit. So we really appreciate it. I think we've got a great program. Dr. Barbara Pickut, who's a movement disorder specialist at Michigan State University. She is going to talk about living well with Parkinson's, and I think you are all going to really enjoy and benefit from her presentation, and she will be with us shortly. We've had a couple technical difficulties, but I see we've got 41 people on the call. If you should be able to see a slide that says Living with Parkinson with Dr. Barbara Pickut's information.
And you can hear me?
Hello?
You can hear me?
You've got an echo.
I know.
Are you using your phone as well as the audio on your computer?
No.
No, just audio.
Okay. Kelly, any suggestions?
Dr. Pickut, are you still logged in twice?
Yes, because I'm trying to run.
So if you can just mute one of your sessions, it'll take the echo away.
And Dr. Pickut, I've got your slides up, okay? So you don't have to worry about that. I can move them along as you speak.
Can you hear me?
Yes, with an echo.
Yes. How's that?
That's better.
But you don't see me.
No, but if you tell Mary Sue when to switch to the next slide, she can switch.
Okay. Hello, everybody. Thank you for your patience with the technical difficulties. And I saw some familiar faces out there, and my special best greetings to you all. So it's an honor and a pleasure for me to speak with you today about living with Parkinson's. And I'm happy to have co-created this with the Michigan Parkinson Foundation. Next slide, please. So setting the stage for today, I would like to speak about the uniqueness of every individual person with Parkinson's, also touch on your role in the healthcare team, say a word about social engagement, and we'd like to focus on the quality of life. So what is Parkinson's? Parkinson's was first described by Dr. James Parkinson, actually in an essay on the shaking palsy in 1817. He described 6 people who had common characteristics of a resting tremor, a stooped posture, a gait disturbance, and diminished strength. Now, what is Parkinson further? We know it's a multi-system, multi-neurotransmitter disorder. Now, what does that mean? It's not only the motor system that we see, which is largely influenced by dopamine, but also mood, behavior, and cognition, which are also, as their chemical messengers, utilize serotonin, noradrenaline, and acetylcholine. So we see when we have Parkinson's that we have a loss of dopamine-producing cells. And these dopamine-producing cells, when they're affected by Parkinson's, they form what we call Lewy bodies. And these Lewy bodies are cellular inclusions. So you see here a slide of cellular, a microscopic slide, where you see this ballooning cell right smack dab in the middle, sort of like a target, and that is a Lewy body. And what impact that this has is the fact that in these cells, these nigral cells, in the substantia nigra, black substance, You see that on the right side of your screen, sort of looks like Mickey Mouse, if you will. The substantia nigra is where these dopaminergic cells are, and these dopaminergic cells project to the striatum or to the motor area of the brain. And when we have Parkinson's, you see below that the substantia nigra is paled. It has a pale color, and that's because there's a substantial loss of cells. Next slide, please. So that when we lose about 60% of these dopamine-producing cells, we may start to have symptoms, because at that point we have about an 80% reduction of dopamine in the brain. And what's the significance of dopamine here? Well, in this slide, you see two parts, each of different neurons. So two neurons that are talking to each other, as it will. And the way they communicate is with this substance, this chemical messenger, this neurotransmitter called dopamine. Next slide, please. So the symptoms, I'm sure, are known to all of you and include bradykinesia, which is slowness of movement, tremor, rigidity, and problems with balance. Next slide. Bradykinesia can come to fore as incoordination or weakness. We might experience difficulties with buttons, with dressing, self-care, combing, shaving, putting on makeup. There might be some difficulties with typing or writing, as well as cutting up food. We also experience a slowness or fatigue, unable to keep up with others, for example, or sometimes having to take longer to complete the daily tasks. The tremor that we experience is predominantly at rest, and it can occur with activity as well. But as you probably know, up to 30% of people with Parkinson's do not have tremors. There's also rigidity, and that's a stiffness of muscles. People often report that it begins in a shoulder or a hip, and there might be some cramping or spasms involved with this. So we know about motor symptoms. Those are very visible, but there's also non-motor symptoms, and there's a lot that we don't know about this, and it's often not talked about in a clinical exam. Non-motor symptoms, some of them can come up even years before diagnosis. Things like depression, constipation, loss of sense of smell, sleep disorders, and pain. And these symptoms may evolve over time. Some of them may even go away. Some others may develop, like anxiety, panic attacks, fatigue, apathy, and cognitive changes. Then the next slide shows you a whole host of symptoms that are related to our autonomic or automatic, if you will, nervous system. Things like constipation and delayed gastric emptying, so having a slower delay or a slow delay of your stomach. And this is particularly important when you're taking medication. Impotence can be an issue, as can urinary problems, as well as blood pressure falls upon standing or standing a long time. Regulation of heat, which may produce excessive sweating, sensory disturbances, and difficulty swallowing. So we did a study looking at 215 people who came to our movement disorders clinic, and we examined how many non-motor symptoms were present in these people. And we found that there was a median number, so an average number of 8 non-motor symptoms per patient. And in at least 30% of the patients, there were 12 non-motor symptoms. We also saw that there were an appreciable amount of non-motor symptoms in people with just beginning Parkinson's, and also that non-motor symptoms increased together with disease severity. So what this becomes then, it's as if the motor symptoms are just the tip of the iceberg, and this large swirling conglomeration here of non-motor symptoms is under the surface. And again, often not talked about and not frequently enough addressed. So just to let you know, and you can probably again tell me, I can learn much from what you all have to say, but these symptoms can be overwhelming. And it's important to know that not all people get all symptoms. Some of the things that we're feeling, of course, could be from other conditions. And it's also important to know there are methods to help with these symptoms. And so it's important that you report these things to your healthcare provider. That's in fact part of your role in this person-centered care, so that it becomes very important to document the symptoms and changes that you're feeling. Keeping a journal is helpful. And also important to note there is what has changed precisely. So what is it that's bothering you, and when did it start? And are there things that make it better or worse? And is there any, for example, any relationship with taking your medications? Do the symptoms get better or worse? And, you know, when you're cataloging these things, you will find, of course, that things are not the same from day to day. They never were, and they never will be for everyone. And some of these symptoms come and go. That's also important to note. In general, yeah, that's fine.
Oh, I'm sorry.
Not at all. I appreciate your helping, Mary Sue. So in general, these symptoms vary from person to person. So often when we're talking with colleague Parkinson patients, you know, we might think, oh, that person has such and such, maybe that means I will get it. That's not necessarily true, as you probably already understand. And even if there's a symptom that you have, such as pain, that's being treated with medication, the response even to that can vary from day to day. Next slide, please. So who gets Parkinson's? Well, we see the average age at diagnosis is around 60 years. And then depending on which reference you use, we see that men have 1.5 to 2 times as much Parkinson's as women. And this seems to be a worldwide phenomenon. Approximately 5% of people who develop Parkinson's, in them, it occurs before the age of 40. We call this young onset. Family history is reported in 15% of people. And important to know that not all things that are diagnosed with Parkinsonism is Parkinson's disease. We have certain medications that cause Parkinsonism. We also have vascular causes, being small strokes in the brain, that actually very many people have. And sometimes if these strokes are in a particular area, they can cause a vascular Parkinsonism. Now, actual genetic forms of Parkinson's is thought to be around 10 to 15%. So there's not much we can do about that if we have that genetic background. But we know even with that genetic background, there's epigenetic phenomena. And what that means is that environment plays a role in the expression of this Parkinsonism. Factors such as pesticides, head injury, stress, diet, physical activity, and smoking all have robust indications that they play a role in Parkinson expression. So how should we approach treatment? Well, of course, one of the main goals of any treatment is to reduce the incidence and severity of symptoms. We also want to maintain independence. And it's important in this that we work together as a team. Again, going back to the person-centered interchange between yourself and your healthcare provider. And what we really need, and as I'm sure you all agree, is that there needs to be more primary and secondary prevention and disease-modifying strategies. So what might this...
How is it treated? Okay.
Hi, somebody's mic is not muted there. So yeah, how is it treated? A very good question. I just heard someone read it. So the first line of treatment is maybe not medication. Sort of debatable about what the first line is, but let's talk about what we have here. Exercise is a treatment for Parkinson's, as is stress management. Rest and relaxation is important. Nutrition is important. There's more evidence coming up for the Mediterranean diet and avoidance of simple sugars and carbohydrates. Rehabilitation therapies such as occupational therapy, physical therapy, and speech, as well as mental health counseling, education, and support groups. Next slide. So what direction might the research be pointing to? Well, there are indications that both lifestyle and environment are factors that may play a role in determining the incidence and evolution of Parkinson's disease. Life stress has been proposed to be a factor for Parkinson's disease. And this has come out of recent studies that have shown that major life events, particularly negative ones, can have an impact on the progression and actually the start of Parkinson's disease. And it seems as though that there's some idea of it's a matter of how these events are coped with at the time. Evidence also suggests that there's a significant emotion, yeah, it was the last, I'm sorry, and the mechanisms do not seem clear in how this coping mechanism either works well for us or leads to psychological stress, which leads to physiological changes. Next slide, please. So exercise has been shown to have several beneficial effects. In 1992, one of the first studies that showed a beneficial relationship between physical activity and Parkinson's, this group reported that the risk of Parkinson's disease was reduced in men who played sports in college and adult life. And that was back in 92. Since then, there's been much research done on the physiological changes of exercise in people with Parkinson's. And one mechanism that may be playing a role here is that exercise influences the production of neuroprotective growth factors, so growth factors that protect brain neurons, such as brain-derived neurotrophic factor, and also a decreasing of dopaminergic neuronal loss and reducing oxidative stress secondary to exercise. Next slide, please. Very interesting study came out last year in 2019 by J.J. Kwok, who compared yoga for people with mild to moderate Parkinson's versus conventional physical therapy, which consisted of stretching and resistance training. And this group showed that the yoga program was found to be as effective as physical therapy in improving motor dysfunction and mobility. And in addition, they found that there was a reduction in anxiety, depressive symptoms, and an increase in spiritual well-being and health-related quality of life. Next slide, please. We looked at offering mindfulness-based stress reduction to people with Parkinson's back in 2013, and we showed that there were measurable changes in the actual brain gray matter, so the actual structure of the brain in terms of density, and this was shown on MRI scans. And these changes in the brain structure were in areas that are relevant to Parkinson's disease. In this particular study, we also showed that there was a significant improvement of motor function. Next slide, please. So that's, in a nutshell, looking at non-pharmacological interventions for Parkinson's. Now let's take a look at what the medication, the pharmacological interventions have for us. So it's important, again, as you being the main actor in the Parkinson team that you be in the know about your medications. Why is this important? Through you inform the team. You inform the other people who are with you in this to help them help you, to give you good advice about what you should be doing in relation to medication. Therefore, it's important to know what the dose is, when to take the medication in terms of timing and food. Also, how to know, so that you know how it works. What's it doing? What can you expect? What should be improved? Or what should be improving? What are the side effects and what to report? Also important to know is there interaction with other medications, and particularly food, as we know the absorption of the Sinemet or carbidopa-levodopa is influenced by protein. The same receptors that recognize your levodopa recognize protein. So if they're full of protein, the medication will have a chance just to pass by and not be absorbed. So we talked about the importance of a diary. Again, I would like to emphasize this. Very important to keep a list of things that change over time. And also, it's a good idea to carry a wallet card, which contains a list of your medications and your medication schedule. So this is a partial list of medications that are offered to people with Parkinson's. And you see it's the dopaminergic, which is our medications that have been used for 50 years, such as levodopa, which is still the gold standard after all this time. There's also the monoamine oxidase inhibitors that can be used, the MAOB inhibitors, dopamine agonists such as ropinirole, COMT inhibitors, such as entacapone and amantadine, which has a weak dopaminergic action. We also use this for dyskinesia, for example. And there's other classes of medication, such as trihexyphenidyl or Artane, that's sometimes used for tremor, but may be interfering with cognition, so might affect memory. And then a new medication, Neurians, that has a novel non-dopaminergic manner to improve Parkinson's symptoms. So for people who are taking carbidopa-levodopa and experiencing off, then FDA approval for Neurians was just late last year. Next slide, please. Another therapy that we can consider that is non-pharmacological, of course, is deep brain stimulation. And in deep brain stimulation, there's a precision placement of an electrode into the brain to a very specific place. And that delivers an electrical stimulation which dampens tremor and rigidity. Now, the target sites that may be chosen for you may vary depending on symptoms, and that will be discussed with you by the surgeon. So you see here a cartoon of someone who has a deep brain stimulation. This is all not visible on the outside. That battery that you see at the chest, that's called the internal pulse generator, and that is the place where your healthcare provider will program the system. So deep brain stimulation is used to treat symptoms that are responsive to levodopa, such as tremors, and tremors that are refractory to medications or that don't respond to medications. Deep brain stimulation may also allow the reduction of medications, and by doing so, can decrease side effects from medications, such as dyskinesia or motor fluctuations. Another approach to people who are having difficulty with their medications, this is later on in the career with Parkinson's, is a carbidopa-levodopa, which of course is Sinemet, carbidopa-levodopa, but in a form that's a gel suspension or an enteral infusion. And that you see a person cartoon holding something, and what that person is holding is a duopa pump. The upper part of that pump, you see sort of a keyboard. Well, that's how this system is programmed. And the bottom half of that is a cassette that holds the carbidopa-levodopa gel suspension. And what Duopa can do is to reduce the off times, because as you see, the medication is introduced into the body at the stoma site, and it's given to the body continuously. So there's no pill taking anymore. It's all the medication you need comes through this pump technology. Next slide, please. So I want to impress upon you, and as you know, and as we look around among us, every person is unique. And that is also pertains not only to what's on the outside, but what's on the inside. That is your physiology. So we all need to, we, the healthcare providers, and all the people in your team, are gaining more and more sensitivity to this. I'm convinced of that. I've been doing this since 1992, and I've seen over the years that we have become much more sensitive to people individually and what their particular needs are, not just in terms of psychological needs, but also physiological needs. How to precisely arrange medication for them and not just a script from a book. Next slide, please. So this idea of person-centered care on the top includes, of course, the person with Parkinson's and also their immediate environment, their family, their friends, their significant other, their care partners. Within this is also the healthcare team. And then there are also people that we need to consult for legal and financial resources, as well as mental health resources and community resources. Next slide. So the healthcare team around you consists of your neurologist, possibly your movement disorder specialist, primary care provider, maybe a physical medicine and rehab physician involved, or they may write a script for their team for physical therapy, occupational therapy, speech and language. Mental health professionals are sometimes an integral part of a team. It's difficult to find the professionals, but we do have some very special folks in Michigan that are specialized with people that have Parkinson's. Also your pharmacist, nurses play a key role. They have been socialized to listen to people generally, and very thankful that we have them among us. Social workers can help us with a number of issues. And then we have neurosurgeons who help us with DBS, neuropsychologists who take memory testing and cognitive testing, and other specialists such as gastroenterologists and urologists, and on and on. Next slide, please. So there are resources in our community that we can turn to for help. There are support groups, exercise programs that are offered, and now many online, wellness programs, also online, educational programs, such as the one being sponsored today by the Michigan Parkinson Foundation, community resources, and then books, articles, and websites. And if we go to the next slide, you can see that Michigan Parkinson Foundation is here to help you, and they are a fantastic source of information to all of us, providers and people with Parkinson's, in getting you the best care that we can. Next slide, please. And I would like to thank you for your attention and your patience with us in getting this webinar up to you today. Could you go back to the last slide, the previous slide? Mary said, thank you, so that everyone can see how they can best contact you. Thanks, everybody.
Thank you, Dr. Pickut. Do you have some time for some questions?
Oh, I sure do.
Okay, Kelly, do you want to unmute everybody? Okay, I want to thank Dr. Pickut. I always learn so much, and I want to, what I love is that she really included information on exercise and just, you know, how important it is. So we've opened up the questions now, so feel free. Maybe the best way might be, where's the chat, Kelly? Do you see the chat? I'm going to stop the share.
There. Or they could do.
Right down at the bottom. If you guys have questions, and feel free to click the
Yeah.
chat button at the
Does
bottom.
everybody see the chat?
Yeah, right here.
You can ask the questions that way. That way we're not talking on top of each other.
60 people on.
Does everybody see where the chat is?
Yeah.
You see it, Keith?
I don't even know what it is.
Okay, well, go ahead. Did you have a question?
Yes.
Hi, Jen. Art, what's your question?
What was the question? Jan and Art? Jan and Art, did you have a question? You can go ahead and ask it.
Bob?
I'm not hearing it. Good. All right. Folks, if you have a question, just go ahead and ask it. You don't have to do the chat. Just go ahead and ask it. You're all unmuted.
I want to ask about.
We have a question.
Go ahead.
My husband, when he's the one with Parkinson's, and when he had a colonoscopy last year, there were, issues with there. When they did the procedure, the doctor said that he wasn't completely cleaned out. And we're just wondering, do other people experience this issue, and how have they gotten around that so that they can have a clean colonoscopy to have a thorough exam?
Dr. Pickut, did you hear the question?
It looks like we lost her, Mary Sue.
Oh, no.
Yep, if Mary Sue,
Yes.
can I speak to that?
Please do.
Yeah, my son had the same difficulty. He, went through the whole cleanup thing the first time, and he did go for it the second time, and it was successful. And what he was very careful of was actually, I don't know how many days beforehand, but eating very light, and also very careful with all the fiber and everything. The eating days ahead, not just a day or two ahead, but maybe think of 3 or 4 days ahead of really addressing the diet. And then he had a successful colonoscopy. That's all I can speak to that.
So bottom line, he ate light. Did he add a lot of roughage to his diet those 3 days before?
No, I don't think so. I think he ate things like soup. And
Okay.
I don't know that it was very thick soup. Soup, probably yogurt, but things that not like meat, not
Okay.
don't think beef or pork or any of that. I think he left all of that alone. He ate a very light meals, probably not salads to any.
Okay.
But he does. So that was his experience.
Okay.
Thank you.
Yeah, we appreciate it, because he had eaten on Sunday, and then we did, he did a prep Monday night and a prep Tuesday night. had the colonoscopy on Wednesday, still wasn't clear. And it,
Mhm.
and so that's why we're want them to come back and have it again in August. And so we're just wondering
In any
you know,
place.
what, yeah, we'll kind of change our meals a little bit and see if that
Yeah.
helps.
Perhaps if you have a dietitian or anyone from your primary doctor, any question there that you could actually look at a list of food that would be suggested to really help you help the system to be cleared out ahead of time.
Right. We appreciate it.
Here's another question. What does Dr. Pickut think of vigorous exercise slowing or stopping the progression? Dr. Pickut, are you still back on?
Do you hear me?
Yes, we do. Yes.
Okay, super, super. So the question was, if I may paraphrase, that is there an influence of exercise on Parkinson progression? Is that right?
She's asking specifically, what do you think of vigorous exercise slowing or stopping the progression of the disease?
Okay, so I think if you'll allow me, I think perhaps what key there is vigorous for whom? Vigorous for me might be different than for my 21-year-old son, right? So vigorous is a concept also that we have to judge in terms of your heart health, so your cardiovascular health. We need to see if what level of fitness is there and move from there. So in other words, it would be important to speak to your primary care physician about that. I think that at a certain level, a certain intensity of exercise is important. But again, that is so individual. It's a little bit like prescribing medication, isn't it? It's not one size fits all. I know in a way that's a roundabout answer, but I think a very relevant answer if we're dealing with individuals. So on a population level, on a higher level, yes, I think that there's some degree of effort that needs to be expended to have the benefits of exercise.
Okay, thank you. Here's another question for you. Has there been any sign of Parkinson's causing more symptomatic problems with COVID-19 infection or any other findings so far that there's a relationship between the two of them?
I think that there are some things emerging in terms of breathing. The first indications are no, not particularly, but of course most of us when we have Parkinson's are of a certain age, most of us, right? And therefore COVID hits harder too the older we are, that we all know. I think there's no particular reason to think that because one has Parkinson's that one would be more at risk, except some of us don't breathe as deep, and the general health plays a role in there as well as the.
I thought Dennis had his number in here.
So I think that the immune system, getting that in check and getting that as best as we can have it is very important for everyone. And for the same reason, we believe that people with Parkinson's, we think that vaccination against the flu might be important. For those same reasons, we want to protect people who have less robust health than the youth.
Okay, thank you.
I got a question.
Go ahead.
I feel a pressure in my head. Like I sit around and I feel this pressure. I open my mouth and it's sort of like it relieves it. And if I chew, there's some chewing gum that I chew. That will also relieve the pressure.
Here's on an airplane.
Yeah.
I had a dentist appointment to have a root canal, because when I talked to the doctor, he says, that might be a cause that you need this root canal. Well, I haven't had the root canal because all the other stuff going on.
Oh, yeah. Well, thank you for asking your question. Hard to say, there's a joint there. There's a joint that if you open your mouth, like if you put your finger right in front of your ear, not in your ear, but just in front of it, and you open and close your mouth, you can feel that something moves. And that's your temporomandibular joint. Okay, so there's a lot that can go on in that place. We're talking all day, maybe less now that we're in quarantine, but generally we're speaking the whole day long. And there's teeth there, and there's all sorts of ear issues that could be there. So that is not an uncommon complaint. I would follow the advice of your healthcare providers, particularly your primary care doctor, to help you coordinate between specialists.
Okay. Thank you.
I have a question.
Go ahead. Yeah.
Could you talk about the Mediterranean diet and how it affects the medication? Does it make it better? Does it make it, or the foods that help the medication work better?
Well, thank you. That's a very interesting question. So the Mediterranean diet does not make the medication work better per se. Mediterranean diet is a diet for general health and well-being. So part of the issue is that the Mediterranean diet, although it's not a high protein diet, it's not like we know the Atkins diet and other high protein or ketogenic diets, but it is a balanced diet, and we do have evidence in conventional medicine that this kind of diet is healthy for our blood lipid profile, so the cholesterol profile. So that's one thing it's good for, and it increases general health. So one thing we want to know is if we do eat more fish and vegetables and stay away from simple carbohydrates and sugars, when we're eating those proteins and we take Cinemet, we want to try to take our Cinemet an hour before or after a protein-rich meal. And a protein-rich meal, again, is fish, eggs, meat, cheese, nuts, things of that nature. So the Mediterranean diet weighs heavily on fruits and vegetables, also staying away from red meat. Generally, you can Google it, and there is a lot out there, diet plans and meal plans for the week, etc. Sugar, when our sugar in our blood, because we've eaten too much sugar, if that goes up and down a lot, it doesn't particularly add to a good feeling. So we think sometimes we need sugar, and that's something that we see when we have Parkinson's too. To fight that fatigue, sometimes we reach for sugar things. But the up and down, so sugar goes up and it affects your insulin, and then we get a low blood sugar, and then we're sort of on a merry-go-round. And so it's best to avoid, if you can, the simple sugars and simple carbohydrates that we find in cookies and cakes and candy.
Yeah.
Okay, thank you. Here's a question from Gary. He says, after walking outside for 30 minutes, I am very fatigued for a couple of hours afterwards. Is that normal for a person with Parkinson's?
Fatigue is a non-motor symptom with Parkinson's. I don't know how old you are or how fit you are. And that, is something that could be discussed with your primary care. Again, it's a question, like if we were in the same room now and talking, I would ask you things like, how long has this been going on? Are you walking up and down hills? Would it be a good idea to rest halfway through? Would that help? Or would you maybe shorten your walks and see if that has an impact? We would probably look at your cardiovascular system and make sure that is not contributing to any fatigue. So Norm, I hope that answers your question. I know it's roundabout, but I think you can understand from my point of view, without being able to see you and examine you, that's a hard one. But I would discuss that with your movement disorders specialist and or your primary care physician. And maybe take a shorter walk and see if that brings less fatigue to you.
I have a question.
Yes.
I will have several days in a row where I feel I'm taking my medicine on time and I'm on sentiment and I avoid protein around my mealtime, and I will feel just normal. I will say I don't even know I have Parkinson, and then I'll have a couple days in a row where I'm so dizzy and I'm bumping into things. And what causes that I can go and be so normal for several days in a row, and then 2 days I'll be just all off.
Okay. You use the word dizzy there, and so then
Yes.
my ears point when I hear that. Do you take your blood pressures at those times?
I have, and sometimes they'll be high and sometimes they'll be low, and I can't figure anything out with that.
Right. It would be, so when you go to report this phenomenon to your primary care or your movement disorder specialist or your healthcare provider, it would be good if you took blood pressures for a number of days at the same time every day.
Okay.
2 times a day. In the morning, right when you get up, that our blood pressure tends to be the lowest then. And then in the afternoon. And you do that at the same time so that you have a diary. So when you go into your physician or your healthcare provider rather, there's data that on black and white, and then it's easier to advise you.
Okay. Is this Dr. Barbara?
Yes, it is.
Okay.
Yeah.
Well, you were my physician at Mercy Health.
Oh, I'm now at MSU. Yeah. Oh.
Yeah, I miss you. One other question.
Yes.
If I get into a situation where I have not, like we had to fly home this year from Florida, and I just get real stressful. Now, is there anything I can do about that? I just get real shaky and uptight because it's the unknown that I'm worried that I'm not making the right move, or I didn't buy the right ticket or whatever, on that situation.
Yeah, I wish you could see me.
I wish I could too.
Yeah. Maybe Mary Sue can put my email up at the end so people can reach me, because I do have the possibility to see you via telemedicine. But to answer your question specifically, our thoughts are a very interesting thing. And I think that if we learned that more in our youth, it would be helpful. So the fact that you are in an airport or getting ready to go on an airplane is just a thought. There's no tigers running after you or bears. No. But our body reacts the same way just by thinking. I mean, how amazing is that? How powerful thoughts influence our physiology. Because at those times, you're not making this up. Our bodies, when we're under stress, produce different substances, stress hormones. And that's why particularly exactly what you bring up is why we did that study offering mindfulness training to people with Parkinson's. We did a European study, and we did a study at St. Mary's offering mindfulness training to people with Parkinson's to help us recognize as human beings that we are thinkers. I mean, that is part of our specialty on this earth. We are thinkers, and we overthink sometimes to our detriment. And yeah, so breathing techniques, yoga, exercise, mindfulness, learning your thought patterns. Psychologists can help. There's a lot of things. There's a lot of things that can be done to help us live better in our bodies. Everyone, not just people with Parkinson's, everyone. Yeah. Thank you for the question.
Okay, thank you.
Folks, I just put in the chat area to everyone, I put Dr. Pickut's email at Michigan State. Okay, so if you look at chat, you'll see where her email is. Doctor, are you taking new patients?
Yes, I am.
Okay.
And we're in telemedicine now. So I still live in Grand Rapids and commute, but I'm seeing people now via the computer, so.
And folks, we have a neurology referral list on our website, and Dr. Pickut is on there with her Michigan State location to make an appointment for the future, okay? Okay, do we have any other questions? It's kind of quiet out there. If you have a question, just unmute yourself. I'm not seeing anybody. Let's see if I can see anybody trying to reach us. Doesn't look that way.
No, still have 40 folks out there, 46.
Yeah. I think Betty Glick is trying to talk. See if we can unmute her. Let's unmute everybody and see. Kelly, can you unmute everyone? Because I think someone's trying to ask.
Okay. Hello?
Hello.
Yeah, hi.
Yeah.
Hi, this is actually our husband, Steve. I'm the one with Parkinson's.
Okay.
And I have a question about the protein and having protein near your Cinemet. And sometimes it's difficult to schedule hour before, hour after, and that kind of stuff. And how critical is it to have, do you have to have zero protein exposure?
That's an excellent question. You know, we never, 25 years ago, we never talked about protein in Cinemet. Mm-hmm. And a lot of folks did not have a problem, right? So that's curious. It seems that what we don't know and why I can't answer on an individual basis now for anyone is we don't have a measure of how many receptors you have. The whole dynamic rests on the following, that your guts are very smart. Those tubes are extremely smart. And in those tubes, we have what we call receptors. They recognize protein, but those same receptors seem to also recognize the Cinemet. So if we have a delayed gastric emptying, so when we have Parkinson's, our stomach tends to empty slower, so the food stays in the stomach longer. And then there's also in the intestines themselves a slowed movement through are you still with me, sir?
Yeah, I'm here.
Okay. So then in the gut also, there's maybe when there's Parkinson's, because it's a motor function to move that food around in the gut, right?
Right.
So for some people that's an issue, and for other people it's less of an issue. So it really depends on your experience. So do an experiment. Keep a log. Write down what you've eaten. You don't have to be in minute detail, but write down what you have eaten and when, and how your medication's working that day. You are the expert of yourself, and we don't have the technology yet to go in and count those receptors, but we do know from studies that this is a dynamic that exists. Or we believe this is a dynamic that exists. Let me put it that way. So again, you are the expert. Keep a diary of how this affects you. It won't hurt you. It's not that it's harmful to eat protein with the medication. It's more that you will get less medication into the bloodstream and therefore less positive effect of the medication if less gets to your brain. because it goes from gut to bloodstream to brain. Okay?
Right.
Anything that impedes that pathway will make that there's less medication, less dopaminergic medication being offered to the brain so that the brain can make the dopamine. Does that make sense?
Yeah. On the other hand, I see they recommend if you have nausea to take it with food or.
Sorry? Say again?
If people have a side effect of nausea, I think they recommend taking it with a little food.
Yes, well, that's a different story. That's a different question that you're asking.
Oh.
Yes, we do. Some people do experience nausea when they're starting the carbidopa levodopa. Not everyone does. Not everyone does. And if someone is sensitive to the carbidopa levodopa, then we start with a quarter of a tablet, for example, and get the body used to it. So there are ways to get around that, and that can be discussed with your healthcare provider. There are certainly ways to help that. And if you don't want to eat on an empty stomach, well, then something like a dry cracker or bread, or there's a number of things.
Which is a little bit of carbohydrate, so that's fine.
Yeah. Well, we have good we have good and better carbohydrates to choose from as well, right?
Yeah,
So,
definitely.
Yeah.
Some apple.
Like sometimes, like even today, actually, I'm in a research study. They're doing a comparison of a longer acting to Cinemet, and I've been in that for a while.
Yes. That's wonderful. Thank you for your participation. That's important for us all. Thank you.
Hopefully it'll help somebody.
Thank you.
What was I going to say? Sometimes, like even today, when I got up, my morning dose didn't kick in, and it's getting on an hour and a half, 2 hours. It was way too long. But I find sometimes that happens, and as a last resort, I'll take some carbohydrate. I could have a bagel, or pretzels, or something, or some juice, and I get better right away. But it's like the person who's been sick, and they say if you take this medicine, you'll be better in a week. And the person who doesn't take it, on the 6th day, they say, I've had it, I'm taking it tomorrow, and they get better. So I can't tell if the carbohydrate's helping or it's coincidental.
Yeah, that's interesting. That's interesting. You illustrate that very nicely. That's why it's so hard on an individual basis to generalize. Thank you. But it could be other things. And that. So if you're in a clinical study, then I'm sure you have very bright people who are following you and that can help you with such questions. I would hope.
Very good.
Yeah, I would certainly discuss these questions that you've asked today with them. Blood sugar is also an important thing for the brain. The brain uses
my blood sugar, as far as I can try it, it's been normal. My hemoglobin A1C is upper limits and normal. No family history of diabetes.
Yeah. So it's multifactorial. The body is very complicated, and if you're in a study, I'm sure they know you very well. I'd be interested in hearing what you find out.
Oh, I'll let you know.
Okay.
If they let me know.
Okay. I wish you all the best in your journey, sir.
Thank you.
Okay, we've got time for one more question.
Hello, this is Mike at number 6609.
Go ahead.
Hello.
Hi, Mike.
When I get up at 7 o'clock, I take my medicine, but I find my blood pressure is fairly high at that time. But 2 hours after I take my medicine, I get it very low, down below, as low as 75/50 or so, and I have to lay down for an hour. This is really bothering me at morning, afternoon, getting very dizzy due to low blood pressure.
Yeah, and this is an individual question that points to a larger non-motor symptom, and that's of course what we call hypotension. Not only hypotension by standing, but hypotension in general that some people experience with Parkinson's. And again, I think it's important for you to discuss this with your healthcare provider, and how you can play your role in this is to write down the specifics, you know, how many days a week this happens, precisely when you take your medication, when you eat, and what your blood pressures are. There are devices that people can wear 24 hours a day as well to measure blood pressure, and that it sometimes becomes necessary to monitor in order to help you on an individual basis. Does that address your question?
Well, it does, but for 3 years we've been having trouble. I've been taking detailed logs and seeing cardiologists and doing stress tests and so on, and haven't figured a way. There's no easy way to raise blood pressure without making it too high when it is normally high.
Yeah, there are, you know, there are things like pressure stockings and abdominal binders. There's a number of things that can be tried.
Yeah.
I don't know you, so of course I can't give medical advice to you specifically. But there are binders and things that can keep your blood pressure higher toward the, you know, toward the upper part of your body, which might decrease your hypotension.
Yeah, I don't give low blood pressure is usually when I'm sitting or laying down. It's not, has nothing to do with standing. But in any case, I'm also losing weight. Does Parkinson's affect your ability to utilize food, nutrients to maintain adequate weight?
Not directly so. Perhaps indirectly with appetite and nutrition. Also, when we are get a little bit older, we tend to absorb nutrients less well. And then that is a question for the gastroenterologists. If you're taking in enough calories, so if you have a calorie count, that could be discussed with a nutritionist. That's probably an important thing for you to follow.
Okay, thank you.
Yes, sir. Thank you for your question.
Okay. I guess we could do one more question if there's one more.
Yes.
No? Okay. Dr. Pickut, thank you so much for lending us your time and your expertise. This was so helpful. You know, at one point we had 56 people on the call. I'm very grateful, and I'm sure the people on the call all appreciate it. I hope the rest of you have a great rest of the day. It's a beautiful day out. I do have one question. Lori Eberling, where are you? Are you on the beach? We can all see this beautiful background. I'm jealous.
Wonderful.
Yeah, looks like a great place.
It's not real.
It's not real?
No, it's just a backdrop.
Oh my goodness, I've been sitting here so jealous. It's a beautiful backdrop. All right. So I'm going to say goodbye. Everybody have a great weekend and enjoy this good Michigan weather. Dr. Pickut, again, thank you so much.
It was my pleasure. Thank you. Thank you.
All right.
Thank you.
Bye.